So our first speaker for this afternoon session is Dr. Perry Fine. He's professor in the Department of Anesthesiology at University of Utah, and he's chairman of the advisory board of the National Institute of Pain Control. He received his bachelor's degree from the University of California, Santa Cruz. He's medical degree at MCV, which is now VCU, who sponsors this meeting. He was an intern in Sonoma County and resident in the Department of Anesthesiology at the University of Utah, and then he went up to the Smith Pain Clinic at the University of Toronto, the famous, the pain volume that textbooks written by that group, at least edited by that group. And he's got numerous publications in peer-reviewed journals, books, book chapters, CME and web programs. And this afternoon he's going to start off talking about pain and aging.
Before I do start, though, one quick note. I was incredibly flattered to be contacted by Dr. McLean and to be asked to speak at this conference. The previous division chair at University of Utah, John Ward, who is subsequently deceased, he spent decades in that position and developed an extraordinary program at the University of Utah in rheumatology, was one of the first speakers at this conference. So to sort of be bookended with somebody who I have such respect for, I feel very honored and a great sense of appreciation to Dr. McLean for this kind of invitation. Now, that said, we're going to do some back-to-back talks here, but you'll see there's going to be connection. One of the areas of interest I've had pretty much throughout my career has been around pain and aging, largely due to the compelling demographics that even 25 years ago we began to realize was going to confront us over the next, and here we are, 25 years later. From 1990, I started my career on the faculty of the University of Utah in 1985, and started looking and projecting forward with what kind of population we were going to be facing through 2020, and recognized that if you will, if you think of the boa constrictor eating the rat, well, that was us, the baby boomers, and we've slowly moved through the belly of the beast, and there we are, only a few short years away now, and you see that the pyramid, if you will, has become a column. And the implications of this, from the standpoint of the public health, the epidemiology of chronic disease, the economics of healthcare, which of course is, you can't open up a newspaper anymore, it's on everybody's sort of the tip of every politician's tongue. This is sort of what we're currently facing. And of course, the world really has changed dramatically, and largely our systems, both health education, professional education, medical education, no less healthcare systems, no less the economics of healthcare, have not really truly confronted this. But one of the big issues that we face with this change of demographics and this sort of continuate progression of aging is the virtual inevitability of painful conditions associated with aging. Now, that doesn't mean that people with advanced age, no matter how you define that, and of course I define that as anybody who's old is 20 years older than me, and that's an ongoing process. So it doesn't mean necessarily that people have to be in pain, but it does mean that people with advanced age do tend to develop chronic conditions that are associated with pain, and of course this is no secret to you all. Musculoskeletal pain issues, joint and spine tend to be the leading, and then of course there are a number of neurological conditions as well. So you can see sort of from this slide, the prevalence is really very, very high. It's now estimated that about 2/3 of people in the Medicare age group, 65 and older, about 2/3 do have some pain condition that is at least 1 year old. So it certainly falls into the definition of chronic pain condition, and has some impact on the quality of their life, functionality especially, sleep, mood, social interaction, self-care, all those things that we associate with wellness, with health, and optimizing health status. And it's the absence of that, let me go back just a moment, that the absence of that, of course, that leads to decline in health and, in fact, even premature death and morbidity and mortality. If we look at prevalence in various settings, certainly whether it's resident, people staying in their own residences, but certainly those people who are in long-term care have a higher prevalence, and largely due to the kind of chronic conditions they have. This is sort of the who's who, if you will, the rogues gallery of those things that we are confronting as we age. I think as we start out as young people in medicine, it's very hard to identify with older population. We just never think we'll get there. Thank God, I suppose, for the denial of youth. But as we progress as the decades go by and we practice medicine, we start to identify a bit more, I think, with our patients, even to the point where I think the old, if you will, sort of shtick about, patient comes in and starts complaining and the physician says, you think you got problems. Let me tell you, there is this role reversal that we have to be a little bit mindful of. So there's the problem of being youthful and not being able to have any empathy whatsoever for people with these chronic conditions, and the over richness of empathy from us accumulating them ourselves, and to maintain that sort of compassionate but dispassionate sort of objectivity about these things. The consequences, again, are serious and significant, with sleep disturbance, malnutrition, decline in social recreational activities, physical function decline, which is the major thing we measure. It's always sort of ironic, people come to the pain clinic where my practice is an ideal, especially with people with complex and chronic progressive advanced medical illness on a referral basis. And they think that the focus is going to be pain. Well, most of the focus is largely on functionality, because I think we can always do something about functional capacities improvement, sleep, physical activity, self-care, and of course, pain is sort of a gateway towards this. But if we just focus exclusively on pain and not on functional improvement, we don't have any objective measures, if you will, and we're at great risk, which will be a theme of today, of how do we help people without harming them? How do we treat, and especially people with significant serious disease who are limited and highly impacted negatively by their pain condition, and not poison them as we're trying actually to do good. So the first do no harm, balanced against the principle of beneficence, is something we always have to balance in mind. And then of course, on the far right, you see the effects on mood, which are just extremely well documented now in terms of the association of chronic and persistent pain and significant and serious negative effects on mood, which of course becomes almost a chicken and egg phenomenon. Are we chasing after depressive illness, or are we chasing after pain? And certainly it's, I think it's paramount importance, especially with individuals with cognitive impairment, where we also start seeing agitated behavior and they can't verbally communicate adequately to ensure that pain is under control, and we're not conflating the agitation and the delirium perhaps of a cognitive disorder or a drug treatment toxicity with that nonverbal expression of pain that in fact can mimic the same. So the beginning of life, sort of the end of life, the behaviors of pain sort of look the same in nonverbal individuals, but who express it with behavior, and we have to be mindful of that if those are the types of patients you see. So that's mostly, again, the burden of pain. This unique pain signature idea is one I just wanted to share with you. Deb Weiner from University of Pittsburgh sort of coined this. What it does is it allows us, if we think about it this way, in the absence of objective measures of pain, to address subtle changes in behaviors to people who are most familiar with the person. So when we're dealing with older individuals, and especially those with some cognitive impairment and those who cannot verbally express themselves adequately or fill out the kind of tools that we may put in front of them in terms of verbal pain descriptors or linear analog scales or picture type scales, these subtle changes in behaviors, in sleep wakening, in amount of time up and down, in eating, in mood, in expression in one way or another, are often very personalized and intimately associated with the expression of pain. And so talking with family members, with nurse assistants who may be involved in daily hygiene or care, in nursing homes is